The American Dental Association has released 2 reports which update previous reports on the management of the dental patient at risk for osteonecrosis of the jawbone, or ONJ, while taking bisphosphonates. The first report, dated December 2011 and posted on the ADA website, is entitled Managing the Care of Patients Receiving Anti-Resorptive Therapy for Prevention and Treatment of Osteoporosis. Recommendations from the American Dental Association Council on Scientific Affairs. The second report was published as an executive summary on the same topic in December 2011 issue of the Journal of the American Dental Association. Both reports update a 2008 report on the management and care of patients receiving oral bisphosphonate therapy, which was described in an earlier newsletter. I'd like to welcome Wayne Aldrich to Take 5, and we're going to be speaking about the specialist and GP referral. Welcome, Wayne.
Thanks for having me, Marty.
Dr. Aldrich is a periodontist and implant specialist. He's board certified by the American Board of Periodontology and a clinical assistant professor in the Department of Periodontics and Dental Implantology at Stony Brook University. So Wayne, what are we seeing now between the general dentist and the periodontist? Is the referral pattern still the same based on the economy?
Very interesting question, Marty. What I seem to be seeing, and I'm blessed, I feel I work with some of the best dentists in the country. I don't think it's a dentist-driven that they're not sending out more. I think most dentists are ethical. I think that if a patient has a problem, we tell them what the problem is. But I think based on finances, some patients are less apt to go to a specialist.
The role of periodontics is changing. I know it's not the same as when I was in dental school.
No, I would agree with you. An old term for periodontal specialist was a gum gardener. All we did was clean teeth. Okay, that's probably 1/3 of a periodontal practice these days. There's still patients who have that level of disease who need to be co-managed.
What's the criteria now of doing traditional quadrant surgery or implant placement? And is the dynamic of that changing?
Sometimes it's a fine line to walk with a patient. Can a tooth be saved or can it not be saved? Well, one of the things we look at when it comes to placing a dental implant is if the root of a tooth is only 10 millimeters long, and we may need to do something to save that tooth, but we're going to take away 1 or 2 millimeters of bone, well then maybe we want to place a dental implant. Because now we're getting to the point where there may not be enough bone to place a dental implant. There's also vital structures in the jawbone. There's nerves, there's sinuses that can limit at times what length of an implant we can place. So sometimes even though we can save a tooth, we tell the patient it's in their best interest perhaps to have it out and have a dental implant.
So things are changing. Are we looking to save teeth the same way as we did before, or are we looking at other options long-term for replacement of teeth?
Well, absolutely. Look at it this way. When we take a tooth out, 20 years ago we would take a tooth out and we'd squeeze the bone together. That's what we were taught in dental school.
Yes.
Well, that bone is what we need potentially for a dental implant down the road. So many times now when a tooth comes out, we'll place a bone graft in there, even if they're going to get a bridge. That's fine. A patient may say, I don't want an implant. But great, let's preserve that bone, because that's bone you may need 10 years from now if that bridge should fail. And your bone and your teeth also support your facial structures and prevent everything from collapsing in. So the value of your teeth is huge. The value of replacing them properly has great value in the long term for a patient.
Thank you, Wayne. That was wonderful information. The GP to specialist referral is an important part of all of our practices. And when we're looking at periodontics now, it's not just surgery. It's other things that we have to take into account. So think about it next time you have to refer your patients.
They see themselves primarily in a mirror. They're not used to looking at themselves at all the way normal people look at them. So I'm thinking when we go to show patients pictures, it's not a bad idea to flip those pictures digitally in a mirror image. That way they're seeing themselves as they normally expect to see themselves. It also helps to explain what's on their left and what's on their right. Because when we show pictures to the patients the way we see them, it can often be very confusing for them. But sometimes patients can't even tell you why they don't like their pictures. They just say, I hate pictures myself. And yet when you flip the pictures, It all goes away. So think about flipping those images. It takes 2 seconds. It can really make a difference. My pleasure.